Hi, everybody. I'd like to welcome everybody to the top 20 studies of 2023. This is an annual event that we hold every year, and I'm indeed very honored that you've joined. If this is your first year, welcome. And if you've joined before, welcome back. There's really some wonderful research going on in the world of hair loss, and it's really my great pleasure to review with you the studies that are happening now and the significance of these studies and how they're changing what we do in the clinic. And so, with no further ado, I will get started. For those of you who don't know me, I'm Dr. Jeff Donovan. I'm a dermatologist. I practice in Canada, and my practice is exclusively devoted to hair loss, all types of hair loss. This webinar today will last perhaps 2 hours, 2.5 hours. Depends on how much off script I go, but I certainly am quite enthused about these 20 studies. This recording will be on our Evidence-Based Hair podcast, a podcast that we have on Apple, Spotify, etc. It'll also be on the Donovan Medical YouTube channel, and so those will be available for your reference in the event you can't stay for all of this. They are all really wonderful studies that encompass the breadth of hair loss medicine, ranging from alopecia areata to scarring alopecia to androgenetic hair loss to telogen effluvium. It really is an array of studies that really change the conversations we have with patients and change what we do in the clinic. And so I'll be reviewing studies related to dermatopathology, androgenetic hair loss, telogen effluvium, studies related to scarring alopecia, and we'll begin with dermatopathology. How do biopsies change what we do? A study by Douglas and colleagues in the Journal of the American Academy of Dermatology, which is one of our dermatology journals from the United States, which publishes a lot of hair loss-related research. It was really a wonderful study and will be the study that I open with today. It is a study that tells us, plain and simple, that for Black women with hair loss, you should strongly consider doing a biopsy, because more times than not, you could be tricked with a diagnosis. I really like this study. So the authors from Philadelphia set out to investigate the role of scalp biopsies in Black women with hair loss. Should we be doing more biopsies than we are now? How good are we without biopsies? And so the authors performed a retrospective chart review of all Black women 18 years of age and over diagnosed with hair loss over the period 2015 to 2020 at their academic center, and they found 420 patients. 35% were diagnosed with more than one type of hair loss. 18% were not really given any diagnosis. 18% had alopecia areata, 12% had traction, and 10% had CCCA. 10% of patients in this study underwent a biopsy. Now, the most common diagnosis before the biopsy was multiple types of alopecia, number 1, CCCA, which is a scarring alopecia, number 2, and then no specific diagnosis, number 3. But here's the most important part of this study by Douglas and colleagues. A biopsy changed the diagnosis 70% of the time. That's really remarkable. The most common diagnosis after a biopsy became the scarring alopecia known as CCCA, followed by other scarring alopecias, and the most common non-scarring alopecia was alopecia areata. And after doing biopsies, the proportion of patients that were thought to have many diagnoses going on dropped from 50% to 5%. So many women who came into the office thinking, I have many things going on, left after the biopsy feeling that I just have one diagnosis. Patients who had no specific diagnosis before the biopsy all had a specific diagnosis after the biopsy. And traction alopecia was among the most common diagnoses before the biopsy. After the biopsy, it was reduced dramatically from 38% to 5%. So this is a really important study. And for those patients whose pre-biopsy diagnosis was traction alopecia, once the biopsy was done, the diagnosis became lichen planopilaris, alopecia areata, or psoriasis. So why is this study so important? A large proportion of patients who underwent a biopsy had a change in their diagnosis. And many of those patients ultimately had a change in their treatment plan when they had a different diagnosis. So this is a really wonderful study. It tells us just how important biopsies are in Black women with hair loss. And I often say to physicians that work with me that you should strongly consider doing a biopsy in Black women with hair loss. We underdiagnose central centrifugal cicatricial alopecia dramatically. And this study teaches us that we probably underdiagnose a lot of conditions. And so your threshold to doing a biopsy in a Black woman with hair loss has to be really low. And it should almost be of the opinion, almost be of the instinct that I think I'm going to do a biopsy. I think that's really important because I don't do biopsies in every patient with hair loss. The ability to use trichoscopy or these magnifying devices has revolutionized hair loss medicine. And I don't do that many biopsies because I can make the diagnosis with trichoscopy. But for a patient presenting with hair loss, whose background is one of Afro-textured hair, African descent, Afro-Caribbean descent, African-American descent, a biopsy is really, really useful. And I think we need to have that in our mind because it can dramatically change the diagnoses we make and get people connected on the right treatment. And the study teaches us that we're all overdiagnosing traction alopecia. And not as many patients come into the office with traction alopecia as we think. And so we really need to consider scalp biopsies. I thank Douglas and colleagues for this wonderful study. It really has given thought to just how important biopsies are in Black women with hair loss. So thank you to those authors. We'll move on now to some studies in androgenetic hair loss, beginning with a study by my colleague here in Canada, Dr. Gupta. The title, The Relative Efficacy of Monotherapy with 5-alpha reductase inhibitors and Minoxidil for Female Pattern Hair Loss. So here we're looking at female androgenetic hair loss. And female androgenetic hair loss is common. It increases with age. By the age of 30, maybe 15% of women have androgenetic hair loss. That statistic depends a little bit on where in the world one is. But by the age of 60 or 70, probably 40 or 50% of women will have androgenetic hair loss. Androgenetic hair loss looks different than androgenetic hair loss in men. In women, hair loss occurs in the central scalp and sometimes towards the back as well. But the very front and temples, which are so common to male balding, is not something that we typically see in female androgenetic hair loss. The treatment for androgenetic hair loss in women is Minoxidil, topical Minoxidil, oral Minoxidil, anti-androgens like spironolactone, finasteride, dutasteride, bicalutamide, laser, PRP or platelet-rich plasma, and hair transplants sometimes. These aren't the only treatments. But it's not really clear how well these treatments work relative to each other. How would you rank these treatments? Who would you give first place to, second place to? How would you order these? In 2022, Dr. Gupta sought to rank the treatments in males for Minoxidil, topical Minoxidil, finasteride, dutasteride. And he published that study in JAMA Dermatology. And in males, when he set out to rank the treatments that you see here, dutasteride, finasteride, oral minoxidil, topical minoxidil, the order that he ranked them in from most effective to least effective was oral dutasteride number 1, oral finasteride 5 milligrams number 2, oral minoxidil 5 milligrams number 3. And so you can see that oral dutasteride, oral finasteride, and oral minoxidil are among the most effective of these types of treatments, much more effective than topical minoxidil. So how do we rank these treatments in women? Well, Dr. Gupta set to perform a very similar study looking at how we would rank topical minoxidil, oral minoxidil, finasteride in women with female pattern hair loss. And so they looked for articles in the published medical literature that were in the English language, dealt with female pattern hair loss, had patients that were receiving monotherapy, so just a single treatment with either minoxidil or finasteride or dutasteride, and they had data on the density changes at 24 weeks. And Dr. Gupta and colleagues used this special statistical technique, which looks at what's called sucra values, which gives the ability for statisticians to rank the treatments. They identified 13 studies that were published in medical journals. And how did his group rank the treatments that you see here? How do you put these in order from most effective to least effective in women? Well, the data showed that oral finasteride was the most effective of these treatments at 24 weeks, followed by minoxidil 5% twice daily. So here's the order that Dr. Gupta ranked the treatments in women, again looking only at minoxidil, oral minoxidil, finasteride. It did not examine treatments like laser, PRP, spironolactone, and other treatments. But when one looks at finasteride and minoxidil, oral finasteride 5 milligrams was the most effective. Topical minoxidil 5% solution twice daily was the silver medalist, and oral minoxidil 1 milligram was third place. And this was slightly more effective than minoxidil foam once daily, and these were more effective than 2% minoxidil solution twice daily. And so the sucra scores give us some understanding of the relative efficacy of these, how close they are, and what you can see is that for treatments like oral finasteride and topical minoxidil, the sucra scores are pretty close. And so it's not that oral finasteride is dramatically better than 5% minoxidil solution twice daily, but it is better. And we'll come back to why that concept is important in a minute. But oral finasteride being one of the more effective treatments for female pattern hair loss. This is important data and comes as a surprise. There are colleagues amongst us that really do feel that finasteride has no place in the management of female pattern hair loss. And this study really keeps finasteride on the table. Finasteride is not approved for female pattern hair loss. The only FDA-approved, Health Canada-approved treatment is topical minoxidil. Oral finasteride is harmful and teratogenic to women of childbearing age. And so in some countries in the world, it is absolutely strictly contraindicated, and some physicians will never use finasteride in premenopausal women. But those are separate issues from the issue, how well does it work? And this study by Dr. Gupta keeps finasteride on the table as a discussion point that it is among the more effective treatments for female pattern hair loss at a 5 milligram dose. Oral finasteride 1 milligram, which is the dose for men, is at the bottom of the list. And so it is correct that 1 milligram of finasteride is not effective for women with androgenetic hair loss. but 5 milligrams is among the more effective treatments. 5% minoxidil solution twice daily is better than the foam once daily in this analysis by Dr. Gupta. And the 5% solution twice daily is better than the once daily solution. And I think that's important because many of us have a view that for women with female pattern hair loss, once daily 5%, just as good as twice daily 5%, so don't go to the extra effort. What this study teaches us is that that view is probably incorrect, that 5% solution twice daily is more effective than once daily. All of the permutations aren't in this study. What is the value of minoxidil foam twice daily? That's not here. What is the value of oral minoxidil 1.25, 2.5 milligrams, those higher doses? That's not here as well. And this is a study of minoxidil and finasteride. It's not a study of other treatments we use for female pattern hair loss. It's not a study of dutasteride. It's not a study of spironolactone bicalutamide. It's not a study of topical finasteride, which we also use. And it's not a study of anything more than 1 milligram of oral minoxidil. And so we have to keep that in mind as we review this particular study. But nevertheless, it's a really helpful study. I really like this study because it positions finasteride in a manner which is really opens up important discussion for us all who treat challenging cases of female pattern hair loss. A couple of things are really important to be aware of, and they'll be important as we talk about many studies today. And that is that this is a study looking at data at 24 weeks. It's not a study looking at data at 1,500 weeks, which is how long many patients will need these medications. The treatments for female pattern hair loss are lifelong. All of the treatments, whether laser, PRP, finasteride, dutasteride, minoxidil, they are all lifelong. So we're looking here at data at 24 weeks. We don't really know if this ranking order will hold true after 37 years of treatment. I think in our field of medicine, we think, yeah, it should hold true. If it holds true at 24 weeks, it should hold true at 37 years. We don't know that, so we have to be careful. But I really like this study, and I congratulate my colleague, Dr. Gupta. It leaves many questions open, and we've been discussing this paper throughout the year, and there are many wonderful questions that patients and physicians have asked, and that is a reflection not of the weakness of the study, but the strength of the study. Good studies open up many questions, but the benefits of finasteride shouldn't be downplayed. Remember, it's not a ranking of all the treatments, and so we have to keep that in mind. It doesn't discuss side effects. And so when patients ask me, what's the best treatment for female pattern hair loss? My answer is, we need to talk about what's the best treatment for a given patient. And so that's important too. And when we think about treatments, we think about safety, affordability, how easy is it to use, and how effective is it? And this study doesn't talk about side effects. It only talks about effectiveness. And so when we're sitting across from a patient talking about what treatment should we start, we have to think about safety, affordability, feasibility, and effectiveness. For a patient with severe depression, finasteride may not be a good option, as one of the side effects is rarely an alteration in mood. For someone who's planning to become pregnant very soon, finasteride is not a good option. And so we have to think about safety, affordability, feasibility, and effectiveness at all times. Someone with heart disturbances, we may not use oral minoxidil, or at least we may put it a little lower on the list. Someone with swelling in the feet from various reasons, we may not consider high doses of oral minoxidil because swelling in the feet may be a rare side effect. So we constantly think about safety, affordability, ease of use, and effectiveness at all times. I think this paper will lead to a lot of patients feeling that I need to be on finasteride. And there is a lot of patients already in the world that have that view. I think it's really important to say here that finasteride is not an appropriate treatment for many young women with female pattern hair loss. But when you actually look at the data from Dr. Gupta's study, we can see that oral finasteride and topical minoxidil 5% twice daily have fairly similar SUCRA scores. In other words, oral finasteride was the winner. We have to give it the gold medal in this study. But topical minoxidil is a respectable second place. And so when we think about safety and all of these issues, starting topical minoxidil is still a very reasonable option in my mind for many patients. So the authors here looked at 13 papers from the literature looking at minoxidil and finasteride, and their results show that finasteride tops the list. And I thank Dr. Gupta and colleagues for this wonderful study. We'll go on to another study of androgenetic hair loss before we leave the topic of androgenetic hair loss, and that's a study by Jimenez-Cauhe, a study looking at how safe is it to use oral minoxidil in patients with blood pressure problems and heart rhythm problems. And this is a very nice study published in August. So how safe is oral minoxidil in the general population? Well, two very nice studies from 2021 looked at this. Study by Dr. Vano from Spain and Dr. Sanabria also in 2021 addressed this issue. Dr. Vano's study of 1,404 patients and Dr. Sanabria's study of 435 patients taught us that issues like hypertrichosis or extra hair on the face and body can occur with oral minoxidil. Headaches can occur in a low percentage. Swelling in the feet can occur in a low percentage. Palpitations and swelling around the eyes can occur. The actual percentages that these authors quote is slightly different. The study that Dr. Vano conducted and the study that Dr. Sanabria conducted are slightly different. Dr. Vano looked back at what doctors wrote in their charts and side effects that doctors had collected. Dr. Sanabria and colleagues got on the phone, called people who were using oral minoxidil and asked them directly. And so the statistics that we get are slightly different. But you can see that we have some understanding of the side effects in the general population. But how well is this drug tolerated in patients with high blood pressure? And how well is this drug tolerated in people with heart rhythm problems? This is a very nice study by Jimenez-Cauhe and colleagues, which really addresses this. Should we be starting oral minoxidil in patients with high blood pressure? And what about heart rhythm problems? This study teaches us that this drug is much better tolerated than we would have imagined. And for many patients, we don't need to see the use of oral minoxidil as a contraindication. So it was a retrospective study, and they looked at patients with hypertension or high blood pressure or rhythm disturbances who were being treated with oral minoxidil. And patients had to be under care for at least a month, and this was a multicenter study from both Spain and Brazil. So there were 254 patients in this study, 176 women and 78 men, and the mean age of patients was 56 years. And patients were on between 0 and 5 antihypertensive drugs, so between 0 and 5 blood pressure medications. The mean was 1.45 drugs. Almost 60% of patients were using one blood pressure medication, 32% were using 2, 7% were using 3 or more, and just 1% were on no blood pressure meds at all. The mean dose of oral minoxidil was 1.59 milligrams. Generally in males, we use between 2.5 and 5 milligrams, and generally in females, we use anywhere from 0.625 upwards of 2.5. And the mean duration of treatment was around 11 months. and patients were being treated for various types of hair loss, including androgenetic hair loss, telogen effluvium, alopecia areata, and scarring alopecia. So how well was oral minoxidil tolerated in patients with blood pressure problems? Well, all in all, side effects were detected in 6.8% of patients, and side effects included lightheadedness, fluid retention, malaise, tachycardia or increased heart rate, and headaches in 0.5%. Oral minoxidil needed to be stopped in just 6 cases, or 1.5%. And all side effects went away when the medication dose was adjusted or stopped, and there were no life-threatening side effects in this study. Who are the patients that probably need or most likely to need to stop oral minoxidil? Well, the authors show that the people that are most likely to need to stop are patients on 3 or more blood pressure meds to start with, and patients who are on a specific blood pressure medication called doxazosin, which is an alpha-adrenergic blocker. And so that's really important information, because our hypertensive patients that are on 3 or more meds are patients that we're going to need to really keep a particularly close eye on. The authors compared the data in this study to their data from that 2021 study by Dr. Vagno with the 1,404 patients. And what they found is that their data in patients with high blood pressure was pretty similar to their data in the general population. And so I think that's really important. But there was just a slight increase in lightheadedness and fluid retention in patients that had high blood pressure. And so Dr. Vagno's study from 2021 showed that in the general population, 1.6% of people had fluid retention, 1.7% had lightheadedness. In this study in 2023 by Jimenez-Cauhe, 2.6% had fluid retention and 3.1% had lightheadedness. And so a slight increase, but not dramatic. So that's patients with high blood pressure, pretty well tolerated, slight increase in lightheadedness and fluid retention, but not much. What about people with heart rhythm problems? Well, they looked at 9 patients who had a history of arrhythmias like supraventricular extrasystole, atrial fibrillation, sinus tachycardia, cardiac syncope. 4 patients were under medical treatment with beta blockers or amiodarone, which are drugs to help rhythms. 2 patients had a cardiac ablation, 1 had a pacemaker, 2 patients were not receiving any treatment, 1 had a mechanical valve. This is really important data. These are patients that the vast majority of us who treat patients with hair loss would say, I'm not sure we should use oral minoxidil. But these authors have provided us with really nice data, and there was a cardiologist that participated in this paper as well. Systemic side effects were reported in only 1 patient, and that was a patient with supraventricular extrasystoles who was receiving a drug called carvedilol. This patient had swelling around the eyes and swelling in the feet with a 1 milligram dose, but the swelling resolved when the dose was reduced to 0.25. And no patient had palpitations, worsening of their arrhythmia, or any cardiac side effect, and none of them had needed a modification of their treatment plan. So I think this is really valuable information. We are getting better at treating the general population with oral minoxidil, and now we're faced with situations like, how should we treat patients 60, 70, 80, 90? How should we treat patients with high blood pressure? How should we treat patients with arrhythmias? And so this study teaches us that it's a reasonably safe treatment for the vast majority of patients. This is important for us all to know, and that's why it's one of the top 20 studies of 2023. 34% of people in the world have high blood pressure, and so there's going to be a large number of patients that come through the door into hair clinics asking for help with their hair, and we need to know if oral minoxidil is an option or not. So all in all, the authors found that oral minoxidil is pretty well tolerated in patients with high blood pressure or arrhythmia. In patients with high blood pressure, there's an increased chance of fluid retention and lightheadedness, but it's only a slight chance. What I really liked about this paper is the authors also had some very nice recommendations. For patients that are in good health, that have hypertension that's fairly well controlled on their medications, they can start oral minoxidil without referral to a cardiologist, provided things are pretty stable with their medications, and they may start the dose at bedtime to limit the chances of hypotension or low blood pressure. It's a small chance, but we know that patients on blood pressure meds have a slightly higher chance of lightheadedness. But if you take it at night, you're experiencing that as you sleep. And the authors teach us that we need to be careful if patients are on 3 or more drugs, and we need to be careful if we see on the patient history a drug called doxazosin. And those are situations that increase the chance of fluid retention and lightheadedness. There should be a low threshold for doing an EKG, performing a referral to a cardiologist if there's any sort of a worry. But those are particularly important for patients that are on 3 or more drugs. And the authors remind us quite nicely that there are some patients that should not be on oral minoxidil at all, including prior heart attacks, patients with heart failure that have reduced cardiac function, patients with severe valvular disease, disease of the pericardium, and kidney disease. These are patients that you may consider other medications besides oral minoxidil. But we should have a low threshold if we're not sure for referring to a cardiologist. But for the vast majority of patients that are doing well, healthy otherwise, on one blood pressure medication, we can start oral minoxidil. So I congratulate these authors. I think this is a really wonderful study, and I think it goes a long way to helping the 34% of the world with high blood pressure, giving them options for what we can use in our toolbox. So we move now to studies of alopecia areata. Alopecia areata is an autoimmune disease that affects about 1 to 2% of the world. And it's an autoimmune disease whereby the hair follicle is attacked by inflammatory cells and the hair falls out in those areas. 2 very nice studies have looked at the workforce and how alopecia areata affects workers in the workplace. And I think these are 2 really nice studies that I'd like to review with you now that really open our minds to not only what people experience at home with their family, when they go out with friends, but what they experience when they go through the doors of work each day. And I really like these 2 studies. And we'll start with a study by Gandhi and colleagues titled The Association of Alopecia Areata-Related Emotional Symptoms with Work Productivity and Daily Activity among Patients with Alopecia Areata. A study from January. So alopecia areata, this autoimmune disease, can affect many aspects. Relationships with family and friends, as well as work relationships. And that's where we'll focus today. Prior studies in 2020 by Mesenkovska showed that up to 62% of patients with alopecia areata report making major life decisions around relationships, education, and their career based on the fact that they have alopecia areata. So what are the impacts of alopecia areata on the workforce? Well, Dr. Mesenkovska showed in 2020 that patients with alopecia areata may experience decreased confidence, which interferes with their ability to obtain promotions and other aspects of finding new jobs after unemployment. But it also affects plans for career direction and education, and some patients may seek positions with less public visibility on account of having alopecia areata. A study by Macbeth in 2022, which was a large study of 5,435 adults with alopecia areata, followed what happens to these patients over a 2-year period after diagnosis. And compared to patients without alopecia, patients with alopecia areata were more likely to have time off work and more likely to be unemployed. And so I think we're coming to realize in this last 5 years that alopecia areata has a really important effect on the workplace and productivity at work. And absenteeism, or the time off work that patients with alopecia areata need, is far greater than we give thought to. And the alopecia areata research world is starting to look at this much more seriously. And one of these is a nice study by Gandhi, which we'll review now. So they looked at the effect of alopecia areata on work productivity and how this ties into one's emotions. So they wanted to assess how one's emotional symptoms affect how productive one is at work. And so to do this, they gave patients with alopecia areata a variety of questionnaires that are validated, looking at work productivity and emotional aspects of their disease. They studied 242 patients. The mean age was 39. 12% the mean productivity loss was 12%. The mean impairment in activity was 13%. But what the authors showed, very importantly, is that as emotional symptoms increase, work productivity decreases. And that's really the very important point in this study, that emotional symptoms are very correlated with work productivity. And patients that feel self-conscious, embarrassed, sad, frustrated, these are patients that are less productive at work. And so it's a study that really teaches us that the emotional symptoms that people feel impacts their daily experiences at work. And it's really one of the first studies that quantifies this relationship between emotional symptoms and economic outcomes. And it's a really important study, not only for us to understand what patients experience when they go to work, but also from the perspective of employers seeking to make sure that employees are not only happy and satisfied with work, but are able to carry out their workplace duties in an appropriate manner. And so we're beginning to understand that alopecia areata has a major impact on the workforce. And so I congratulate these authors for really drawing attention to this very important study that the emotional symptoms are very tied in with workplace productivity. Another study looked at workplace, but here not productivity, but bullying. And I think this is a study that is challenging to do, but I think this particular study by Lee and colleagues in skin appendage disorders is a wonderful study that teaches us that many patients, 1 in 5, with alopecia areata are experiencing workplace bullying. When these patients present these issues, if they feel so confident to their superiors or to their managers, sometimes there's some things that are done, but sometimes there's not. And some patients, as we'll see in just a minute, leave work. They leave that job on account of bullying. So I congratulate these authors, and we'll take a look at this study now. It's a subject which really is not explored very much, and we desperately need these types of studies. So workplace bullying is a pattern of mistreatment that happens in the workplace that causes either physical harm or emotional harm. And these authors in this study set out to understand how common workplace bullying is in patients with alopecia areata and how is it being addressed. And so they used a questionnaire known as the Negative Acts Questionnaire Revised Scale, or the NAQR. This is a scale, a questionnaire that is given to patients to understand bullying activities that are going on. It's a 22-item tool that assesses workplace bullying in the last 6 months. And the score, when you give patients this questionnaire, ranges from 22 to 110, A score of 22 to 40 means you're not bullied. A score of 40 to 56 means you're occasionally bullied. And a score of 56 or more means you're severely bullied. And we'll come back to this scale in a minute, but I'd like you to take note of that number of 56. Anything over 56 means patients being severely bullied. And so this NAQR scale looks at several aspects of bullying, including work-related bullying, person-to-person type bullying, and then physically intimidating bullying. And so the questionnaire was administered to the National Alopecia Areata Foundation database. And so patients were given this questionnaire as part of the NAF group. And that's how they evaluated bullying. There was 673 patients that ultimately met the inclusion criteria. So fairly large number of patients included in the study. 80% were female. The average age was 47. And most patients were employed full-time, 63%. 21% of patients experienced workplace bullying. And the average score on that scale of bullying was 56.1. And that's a really important number because that means that the average score of bullying for patients was a score that meets the cutoff for severe bullying. Now, patients that are bullied have to make an important decision, and that is, do I report the bullying? So the authors asked patients that what are the barriers to deciding whether you're going to report it or not. 36% were concerned about the potential for reporting to affect future career options. And 43% were concerned about the overall stress of filing a complaint and all the steps that are needed and all the sequelae that comes after. So what proportion addressed bullying? Well, among the people that had bullying, 160, 75% chose to go ahead and address the bullying behavior. So what do people do when they're bullied? Well, in this study, 25% didn't address it. 26% addressed it with another person in the office. Almost half addressed it with a manager. And 14% addressed the complaint to human resources. And other people addressed it to family and friends and other confidants. But what happens when one actually takes action and says, I'm being bullied? Well, in 30% of patients, the behavior was found to continue. The bullying continued. In 16.7%, the complaint really wasn't pursued. 12% received an apology. In 10%, the employer made some sort of changes. In 20%, the behavior stopped. And so there is some good news here that sometimes when one takes action, there is good that comes of it, but fortunately it's not enough. 16.7% of people said there was retaliation. And in 28.3% of patients, the patient left the job. So I think this is really important. Workplace bullying is a really important problem for patients with alopecia areata. And it's a subject that is filled with emotion and has its challenges in addressing, but we need to address it. These are neglected areas. And I think it's really important that people that treat alopecia areata are aware of this. I think we need to do a much better job making sure that workplace, no matter what types of workplaces there are, understand some of these concepts, because 1 in 5 patients are being bullied. And it's not easy to report bullying. Patients are telling us that they're worried about what ramifications will come if they report bullying, including their future career. And for many patients that address bullying, this bullying behavior still continues after addressing it. And so there's an urgent need to develop strategies to stop this. And I congratulate these authors because the first step is to acknowledge that this is happening and move forth from there. I think we have to also help patients to realize that this is occurring. You're not alone. This is more common than we speak about. And as someone who's, taken care of patients with alopecia areata for a long time and been part of support groups for a long time, workplace bullying is not something that we talk about often. And so I think that it is an area that patients feel uncomfortable about talking about, but this is a great study which gets the subject out there and gets us starting to talk. So I congratulate these authors. So we move on now to some studies of alopecia areata treatment. We'll begin by some studies looking at JAK inhibitors. JAK inhibitors are these immunosuppressive medications which are proving to be helpful in the management of alopecia areata. We'll begin by a study in the Journal of the American Academy of Dermatology by Kazmi and colleagues titled Switching Between Tofacitinib and Baricitinib in Alopecia Areata, a Review of Clinical Response. Baricitinib is a JAK inhibitor that was approved in the United States on June 13th, 2022 for the management of severe alopecia areata. The first JAK inhibitor that was approved, this oral medication. And what happened when that drug was approved is that many patients on other JAK inhibitors started asking themselves, as well as their physicians, should I switch? Some insurance companies, when baricitinib became approved, said, we'll approve baricitinib because it's FDA approved. And so many patients were faced with this decision, if I'm using some other drug, should I switch to baricitinib? And so there's many reasons why a patient would want to switch from tofacitinib to baricitinib. Insurance coverage is one reason. And of course, there may be patients that are using tofacitinib, another JAK inhibitor, and find that it's not really working very well. Maybe I should start baricitinib. And so the authors of this study, Kazmi and colleagues, looked at what are patients' experience when they switch from tofacitinib to baricitinib. And I really like this study. It has some really important lessons. So baricitinib was studied in what's known as the BRAVE AA clinical trials. And Dr. King and colleagues published the results of the BRAVE AA studies in the New England Journal of Medicine last year. And on June 13th, 2022, the drug had the approval by the FDA for severe alopecia areata. And so the authors here from Australia set out to look at what happens when patients switch from tofacitinib to baricitinib. And they included patients that were actually doing really well on tofacitinib and made the switch to baricitinib. They were growing hair quite well. There was no clear reason to switch except reasons like insurance coverage. But the study also included patients that were not really doing so well on tofacitinib, not growing all that well, and they were considering baricitinib as an option to grow more hair. And so they retrospectively reviewed patients in their database from April 2016 to April 2021, and they found 77 patients. The mean age was 39 years. 60% had patchy alopecia areata, 12% had ophiasis, which is a form of alopecia areata affecting the back of the scalp. 13% had alopecia totalis, or total loss of scalp hair, and 13% had alopecia universalis. And the baseline SALT score was 53, and that's a score of severity, indicating that these patients have significant amounts of hair loss. And so there were 73 patients that were first treated with tofacitinib. Of these 73 patients, 30 of them had complete regrowth. They were doing really well on tofacitinib. 35 had partial regrowth and 8 had no response. And what happens when these patients are switched from tofacitinib to baricitinib? Well, there's 4 really important principles in this paper by Kazmi and colleagues. The first principle is if patients are doing really well on tofacitinib, they're growing hair great, then they're probably going to grow hair great when they switch to baricitinib. And so there was 30 patients that had complete growth on tofacitinib. They were doing super well. And 16 of the patients switched over to baricitinib, and all of them retained their good growth. So I think that's a really important point. If you're seeing patients on tofacitinib and they're doing fantastic, but they don't have coverage anymore, there's some reason they need to switch, they could switch to baricitinib, and they'll probably continue to do amazingly well. So that's a really important lesson. We're seeing a lot of patients that were paying out of pocket for tofacitinib, which is very expensive. $10,000, $15,000, $20,000 Canadian per year. And the approval of baricitinib in countries like the United States led some patients to have the option to switch to baricitinib and have it covered by insurance. So these are really important decisions. And they're stressful decisions for patients because they're doing so well on tofacitinib and they're thinking about switching to baricitinib. Well, the good news is they're most likely going to continue to do well on baricitinib. The second lesson in this study is that if patients were doing well on tofacitinib and then relapsed, lost hair, grew back, lost hair, many of them will do even better by switching to baricitinib. So there were 9 complete responders on tofacitinib that had a relapse, and they were switched over to baricitinib. And 55.6 of those patients achieved full regrowth by switching to baricitinib, and 4 had only a partial regrowth of the drug. So I think that's important. The third principle is that if you have a little bit of a response on tofacitinib, it's not great, but it's a little bit better. Some patients will achieve fantastic results by switching to baricitinib. So there was 35 patients that had only a partial response to tofacitinib, and 30% had complete regrowth. 28% had complete regrowth when they switched to baricitinib. So that's fantastic. That's really important information. That if patients aren't really doing so well on tofacitinib, they can still retain hope that maybe by switching to baricitinib, they'll get some better results. That happens in a large percentage of patients. And the final point I'd like to make from this Kazmi study is equally important, and that is if patients aren't responding to tofacitinib at all, they're taking the tablets, 5 milligrams twice daily, and they're not seeing any improvement, then there's not really a good reason to switch to baricitinib. That it's unlikely that they'll have significant regrowth if they're not getting any response at all on tofacitinib. And so Kazmi and colleagues studied 8 patients that really weren't getting any regrowth on tofacitinib, and none of the patients had full regrowth when they switched to baricitinib. And so I really like this study. It's data that we've all been waiting for. And that is, what's it like to switch between JAK inhibitors? And there's a lot of patients out there in the world that are on tofacitinib and thinking, should I switch to baricitinib? What will that be like? Will I do worse? Will I lose all my good regrowth that I've been struggling with? And the answer is that if you're doing great on tofacitinib, you'll probably do great on baricitinib. If you're not doing so well on tofacitinib, but you're doing a little bit growth, there's a chance you'll do fantastic on baricitinib. Not everyone, but some. And so I think this is really, really important data. And this is something that I put into practice often in patients on tofacitinib that are making these tough decisions. Should they make a switch to baricitinib? And it reminds us as well that if you didn't get any growth on tofacitinib, there's no sense going on baricitinib. So I thank these authors for this wonderful study. It's a study that has been put into practice and discussion with patients by myself many, many times in the last year. So we move on now to a study by Dr. King and colleagues titled The Efficacy and Safety of Ritlecitinib in Adults and Adolescents with Alopecia Areata, a randomized double-blind multicenter phase 2b3 trial. This is a study published in The Lancet. This is the study that led to the approval of ritlecitinib for alopecia areata this year. So baricitinib was studied in the BRAVE AA trials, as I mentioned. Ritlecitinib, the second JAK inhibitor that was approved, was studied in the Allegro trials. And so these Allegro trials were the trials, the data for which was presented to the FDA, and the FDA made the decision, let's approve the 50 milligram dose. So the Allegro trials were studies of patients 12 years of age and over who had 50% or more hair loss, and they were randomized to receive either ritlecitinib 50 milligrams or 30 or 10 or placebo with and without a 200 milligram loading dose. And the primary endpoint was how much growth happened at week 24. And then the study went on to another 24 weeks where patients were taken off the placebo and put on ritlecitinib. And if you were already on ritlecitinib, you continued the dose. So that's what these Allegro trials were all about. The endpoint that the researchers were looking for was what percent of the patients had 80% regrowth by week 24, or what we call a SALT score less than 20. And they also looked at many parameters, including eyebrows and eyelashes, and what clinicians thought of the growth and what patients thought of the growth. But the ritlecitinib trials were trials of 718 patients in 18 different countries, 118 different sites, 55% were female, many different races were included. The mean age of patients was 32. But what's so important here is for the first time, adolescents 12 and over were included in this trial. And this ultimately led to ritlecitinib being approved for severe alopecia areata in individuals 12 and over. Patients in the ritlecitinib study started out with pretty severe alopecia areata, and that's really important. These are individuals which, many of them, had near complete hair loss, but the mean SALT score was 90, and a SALT score of 100 means total hair loss. So the mean SALT score was 90, indicating that patients are starting out with quite significant hair loss. And the endpoint that the researchers are watching for so closely is what proportion of patients get 80% regrowth, or what we call a SALT score of 20 or less at week 24. The Allegro trials are complex. They have a lot of study groups. Some patients received 50 milligrams, some had 30, some had 10, some had 30 but started out with 200 for a month. Some had 50 but started out with 200 for a month. And some had placebo. And then after the 24-week time point was up, patients on placebo were switched to ritlecitinib 50 milligrams. But what I'd like to focus on here is the 50 milligram dose, because that's what was approved for the FDA by the FDA. And I'd like to introduce you to how well patients do on the 50 milligram dose. So if we look at the proportion of patients that achieved what we call a SALT score less than 20 or 80% regrowth, which is what is deemed in the alopecia areata research field as pretty good growth. It's not full growth, but it's cosmetically reasonably good growth, 80% growth. Well, at week 24, 23% of patients had pretty good growth. At week 48, that rose to 43%. If we look at the proportion of patients that had fantastic growth, which is a SALT score less than 10 or less, at week 24 it was 14, and at week 48, almost 1 year, 31% of patients had fantastic growth. And so ritlecitinib, this JAK inhibitor, which inhibits JAK3, TEC, these particular enzymes, had side effects which are somewhat similar to the other JAK inhibitors. A small proportion of patients had shingles or herpes zoster. A small proportion of patients had upper respiratory tract infections. There were no opportunistic infections in this study with ritlecitinib, which is really important because ritlecitinib and other JAK inhibitors suppress the immune system. And the concern that we're all watching for with immunosuppressants is there an increased risk of certain severe types of infections? And this study showed that there was no increase in these opportunistic type infections. Some patients had headaches. Some patients had changes in muscle enzymes, which were generally minor and didn't affect the dose or the use of the medication. And some patients had acne, and JAK inhibitor-related acne is a phenomenon that's appreciated for many of the JAK inhibitors. But I congratulate these authors, and Dr. King and authors for their work here with ritlecitinib, and of course Dr. King for all his wonderful work with the JAK inhibitors. And this particular study was the study that really led to the approval of this medication. And so in the United States, we have baricitinib and ritlecitinib approved, and we have just heard in Canada that ritlecitinib has been given the okay by Health Canada. And so here in Canada, that will be the first JAK inhibitor formally approved for the treatment of severe alopecia areata in individuals 12 and over. And so that's really important because it gives formally approved options for adolescents. And it seems that adolescents respond to this medication just the same as adults. And side effects may be a little bit less, actually. And so that's encouraging. The study is a 48-week study here in the ritlecitinib trial. What's really important as we go along is understanding what long-term data is. What happens when patients are on this medication 2 years, 5 years, 10 years, 20 years, and 30 years? Severe alopecia areata often requires lifelong treatment. Not in everybody, but many patients with alopecia totalis and universalis, if they respond to a JAK inhibitor, will require lifelong treatment. And so understanding the long-term side effects are really, really important. And that's the next step with all of these JAK inhibitors. Is there an increased risk of cardiovascular disease, blood clots, infections, cancer? And the data so far with many of these JAK inhibitors looks pretty good. And so we haven't had these in the world long enough. Baricitinib was approved in June 2022, ritlecitinib this year. And so clearly we're in the early days of experience with these medications. We go on now to another study of alopecia areata, which is a wonderful study by George and colleagues titled Incident Rates of Infections, Malignancies, Thromboembolism, and Cardiovascular Events in Alopecia Areata. In an alopecia areata cohort from a US claims database. This is a really wonderful study that tells us that what happens in alopecia totalis and universalis may be a little bit different than what happens in less severe forms of alopecia areata. And so as we're thinking about what medical conditions are associated with alopecia areata, we have to think in our mind, are you talking about alopecia totalis and universalis, or are you talking about less severe forms? because it matters. And this study tells us that it matters. And so let's take a look. It tells us that alopecia areata is not all the same, and that heart disease, cancer, blood clots, and infections appear to me more likely in patients with alopecia totalis and universalis, so complete hair loss, compared to patients with less severe forms. So emerging data suggests that alopecia areata might be associated with adverse events, that patients with alopecia areata might have a higher chance of cardiovascular disease, maybe malignancy, maybe blood clots, or what we call thromboembolism, and maybe certain types of infection. But the data is controversial. A study by Schneeweiss in JAMA Dermatology in 2021 taught us that maybe the risk of certain things like blood clots or venous thromboembolic events are not increased in patients with alopecia areata. And this is really encouraging. The authors here studied patients with various inflammatory skin diseases, including 17,889 patients with alopecia areata, and showed that patients with alopecia areata don't really have an increased risk of blood clots or a decreased risk of blood clots compared to controls. So that was really encouraging data. But there's ongoing interest to study if medications can increase the risk of blood clots or cancer or heart disease in alopecia areata, and understanding what the baseline risk is in patients with alopecia areata is really important. What's the risk of these medical conditions before you start a medication? Do patients with alopecia areata have a higher risk of cancer before starting a drug? Do they have a higher risk of blood clots or heart disease? And so George and colleagues set out to examine some of these very important questions. They looked at the risk of a variety of medical issues in patients with alopecia areata and how it compared to the general population. They wanted to understand how it compares to the total group of alopecia areata, but how it compares in patients with alopecia totalis and universalis, severe forms, and patients with less severe forms. And that's what makes this study so important for us to be aware of. And so it was a retrospective cohort study that looked into medical and pharmaceutical claims data, insurance-related data. Patients' information from the database was from those 12 years of age and over, and patients with alopecia areata were matched to controls. And these were age, sex, and race-matched controls in a 3-to-1 manner. And the authors here looked at, and they sought to compare differences in infections, cancer, heart disease, and blood clots in patients with alopecia areata compared to controls. So there was 8,784 patients with alopecia areata, pretty large number. 599 of those had alopecia totalis and universalis, and 8,185 had less severe forms of alopecia areata. And they were compared, all their medical data was compared to 26,000 patients who didn't have alopecia areata, but whose information was harvested from the databases. And they looked at the risks of infections, cancer, cardiovascular events, and blood clots in these two groups. So are patients with alopecia areata more likely to have certain medical conditions? Well, the authors compared medical conditions in alopecia areata compared to medical conditions in controls. And they found that, for the most part, many things look the same. Same risk of blood clots, same risk of cancer, same risk of heart disease, but a higher risk of herpes simplex, the viral infection herpes simplex, in patients with alopecia areata. And so the authors concluded that only herpes simplex seems to stand out as being increased in alopecia areata. But then the authors went on to compare not just the big group of alopecia areata, but specifically totalis and universalis compared to less severe forms. And what the authors found is that patients with alopecia totalis and universalis had higher risk of many of these medical issues compared to patients with less severe forms. And we'll take a look at this data together. These are the pieces of information that make this study so important. And what this study showed is that patients with alopecia totalis and universalis had a higher risk of infection. Infection requiring hospitalization, infection with herpes zoster or shingles, infection with herpes simplex compared to less severe forms of alopecia areata. And this was markedly higher than in the general population, patients without alopecia areata at all. The risk of cancer was higher in patients with alopecia totalis and universalis compared to patients with less severe forms of alopecia areata, including squamous cell carcinoma and other types of malignancies. And this was much higher than in the general population. In terms of cardiovascular events, heart attacks, cardiovascular angina, ischemic strokes, the risk was much higher in patients with severe forms of alopecia areata compared to less severe forms, and higher than in the general population. So this is a really important study that teaches us that if you're going to look at medical conditions in alopecia areata and study it in depth, you may want to consider studying severe forms and less severe forms because the data is different. And I think this study is really important, that even before a patient goes on a medication like a JAK inhibitor, the risk of some of these issues like heart disease, cancer, blood clots, infection is already higher than the general population in patients with alopecia totalis and universalis. This wasn't a small study. There's 600 patients with severe alopecia areata in this study. So what do we do with this information? Well, it's really important information, and we're not sure what to do with this information. How should we best care for someone with alopecia totalis and universalis? Do we need more screening for heart disease? Do we need more screening for cancer? Do we need more screening for heart disease, blood pressure checks, cholesterol checks, diabetes checks? And if patients with alopecia universalis are at a higher risk for a blood clot, do we need to change our recommendations for the use of oral contraceptives, for example, in women? A medication which also increases the risk of blood clots. So what do we do with this information now that we know this information? Well, it's a really important study. And I think that there's a major push in our field of alopecia and hair loss in general, but specifically in alopecia areata, to group everyone together. Call it alopecia. Alopecia. And these are what we call lumpers, people that group everybody together. Everyone with alopecia areata, stand here. Then there's people like myself who are splitters and say, people with alopecia totalis and universalis, stand here. People with alopecia, patchy alopecia, stand here. The reason that is important in my mind is this study, and that is that the risks of diseases like cancer, blood clots, cardiovascular disease are different in those two groups. And I don't think we're ready to lump alopecia areata together as one entity, because we're learning that these conditions are so different. The comorbidities in alopecia totalis and universalis are so different. And so when you walk into a room and the patient in room 8 has alopecia areata, you have to be thinking to yourself, is this alopecia areata a little patch? Is this alopecia areata 30% hair loss? Or is this alopecia universalis or totalis? Because these patients with alopecia totalis and universalis need us to be aware of the potentially increased risks of cardiovascular disease, cancer, blood clots. And I think we obviously need to study this more, and we need to verify this through many studies, but it's pretty clear that patients with alopecia areata are at increased risk of cardiovascular disease, heart attacks, strokes, diabetes. And we really do neglect this in our field because we're not sure what to do with this data. But I think not being sure what to do and being uncomfortable is okay because this is new information. But I think we really need to pay attention to this information because studies like this by George and colleagues are giving us really, really important clues to what's going on in our patients. And so I'm a splitter. I think that we should be thinking about these groups of patients separately because the risks are very, very different. And I think we owe it to our patients to really be doing everything we can to minimize their risks of heart disease, strokes, blood clots, cancer, infections. And one of the ways we can reduce people's risk of developing these issues is to first be aware that there is an increased risk. So I congratulate these authors. I think this is a really wonderful study. A study that I think about often in my practice as I think about how can I care for patients with alopecia totalis and universalis the best way possible? And is there things that I'm doing that are not maximally reducing their risk of some of these conditions? So we go on now to some studies of alopecia areata and COVID-19, and then we'll leave alopecia areata altogether. I'd like to review with you some fascinating data which is emerging in the world, and that is what COVID-19 does in terms of risk of alopecia areata and what COVID-19 vaccines do. And it is a confusing literature because COVID-19 infection seems to cause alopecia areata in some patients. COVID-19 seems to make alopecia areata worse in some patients. COVID-19 vaccines seem to cause alopecia areata or contribute to alopecia areata in some patients. They get the vaccine and 2 weeks later they have hair loss. But we're seeing in some studies that COVID vaccines actually reduce the risk that some people develop alopecia areata in the first place. And so there's this confusing literature that's evolving, and let's try to make some sense of it with some of these wonderful studies that have been published. Beginning first by a study by Wang and colleagues in Clinical Immunology, a wonderful study from October 2023. The authors here set out to understand how does vaccine-induced alopecia areata come about. The authors recognize that there are some people out there in the world that get a COVID vaccine and 2 or 3 weeks later get a patch of alopecia areata. And so the authors wanted to understand, why might this be occurring? And so they recruited patients into their study with vaccine-induced alopecia areata over the 2021-2022 period. And they compared their results to patients who did not have alopecia areata from vaccines. So there were 27 patients with new onset vaccine-related alopecia areata, and they compared their data to 106 patients who had the vaccine and didn't get alopecia areata. Of these 27 patients, 40% had the Moderna vaccine, 30% had the Pfizer vaccine, and 25% had the AstraZeneca vaccine. 59.6% of patients had an episode of alopecia areata after the second dose. In 22% of patients, it was the first dose that triggered the alopecia areata. And in 18.5% of patients, it was the third or fourth dose of the vaccine that triggered alopecia areata. So the authors wanted to try to figure out, are there certain blood tests that seem to suggest this patient might have vaccine-induced alopecia areata? In other words, if you have a patient that says to you, I think my vaccine caused alopecia areata. One way is to listen to their story. Did they have the vaccine and then 2 weeks later they got a patch of alopecia areata? Or did they get the vaccine and 4 months later they got alopecia areata? It's different. But there's 3 blood tests that seem to be abnormal in patients with vaccine-induced alopecia areata, and that's a positive ANA, higher levels of IgE, and higher levels of eosinophils. IgE and eosinophils are markers often of allergic type responses. So in this particular study, 20% of vaccine-induced alopecia areata patients had a positive ANA, compared to just 4% of controls. Almost half had a high total IgE level, compared to just 10% of controls. And almost a third of alopecia areata vaccine-induced patients had high eosinophils in the blood, compared to controls. And so you can see that control patients still had some positive ANAs, some IgE, and some eosinophils. So these aren't perfect tests, but they do tell us that if IgE levels are high enough, eosinophils are high enough, and ANA is high, you're increasing your likelihood that maybe the vaccine caused alopecia areata. So the authors went on to look at 23 different cytokines or chemicals in the blood that are associated with inflammation. And they found that patients that had alopecia areata after a vaccine had higher levels of CCL18, which is a chemical that attracts immune cells, and higher levels of the pro-inflammatory molecule granulysin. But here's one of the fascinating parts of these authors' studies. These authors are experts in what's called the lymphocyte activation test. This is a test where you take white blood cells called lymphocytes and you add stuff to a petri dish and you see if the lymphocytes get activated or not. And so the authors here did these lymphocyte activation tests. And what they found is that chemicals like granulysin, granzyme B, and interferon gamma were released from alopecia areata patients much more readily in the presence of the spike protein and much more readily in the presence of excipients in the vaccine called polyethylene glycol 2000, which I'll explain right now. So the COVID vaccine, the mRNA vaccines, or the AstraZeneca vaccine, contains the ability to produce a spike protein. So the mRNA can generate the ability to produce spike proteins. But the vaccine bottle also has chemicals called excipients. PEG 2000 is the excipient in the Pfizer and the Moderna vaccine. And these are chemicals that allow the mRNA to be what's called pegylated, or coated with this polyethylene glycol moieties, which allow it to be stable and allow it to get into cells. And so in the vaccine bottle is polyethylene glycol, and the AstraZeneca has polysorbate 18. But when you add these excipients or the spike protein onto T cells in a petri dish, what the authors found is that T cells from patients with alopecia areata produced lots of interferon, lots of granulysin, lots of granzyme B. This is a positive assay test. And so the authors here concluded that the spike protein, which the body is making from the vaccine, and these excipients like polyethylene glycol 2000 in the Moderna and Pfizer vaccine might just trigger T cell cytotoxicity. They might just activate and prime these T cells, and this might contribute to what causes alopecia areata in these patients. And so this is really interesting data and important data which provides us with some understanding and a mechanism to why would patients get alopecia areata 2 weeks after a vaccine? Well, it could be that either the excipient or the spike protein is priming that patient's T cells. The authors went on to show us how do you treat patients with vaccine-induced alopecia areata? And they found that 52% of patients responded really well to treatment. 41% had a partial response and 7% had no response. This is important information as well because we typically think that patients that have alopecia areata after a vaccine have a tough-to-treat form of alopecia areata that doesn't respond well to standard treatments. But what this study teaches us is many patients seem to do fairly well. And 92.6% of patients had either a partial or complete remission. We don't have a lot of data as to how we're best to treat vaccine-induced alopecia areata, but this is information that teaches us that many patients will respond well if they're treated aggressively enough. So this is a fascinating study and really one of the largest studies to address this issue of what is triggering the immune system in patients with vaccine-induced alopecia areata. And the authors here point to the spike protein or these chemicals inside the bottle, especially polyethylene glycol in the Pfizer and Moderna vaccine, as triggering some people. Clearly not all people. Most people that get a vaccine don't get alopecia areata, but there are some patients that have this story of rapid onset alopecia areata after the vaccine. And so a really, really important study. And the authors also tell us here that there's 3 blood tests that seem to be a little bit abnormal in patients that have vaccine-induced alopecia areata, and that's a positive ANA, a high level of IgE, and a high eosinophil count. And so if you're seeing patients that have what they think is vaccine-induced alopecia areata, it's sometimes really challenging to prove, but high IgE, high eosinophils, and high ANA gives you a clue that maybe this could be. And so I really like this study. So the world of COVID and COVID vaccines is complex. There are some patients that develop alopecia areata from the COVID infection. There are some patients that develop alopecia areata from the vaccine. And there are some patients that reduce their chances of developing alopecia areata in the first place by getting the vaccine. So we have all 3 of these scenarios that seem to be here. And so there seems to be some patients that are really predisposed to get alopecia areata from the COVID. And there are some patients that really seem to be protected when they get the vaccine. And there are some patients that seem to get alopecia areata when they get the vaccine. So we have a lot more to learn in this area, but I congratulate these authors for providing us with this information that is so important in the clinic every day. Patients with alopecia areata ask me almost daily, should I get the vaccine? And the answer is that for some people on certain immunosuppressants, etc., it may be an extremely important consideration. But the real question that they're asking is, will the vaccine cause me to have worse alopecia areata? Well, these sorts of studies are important because they're teaching us that for some of our patients, getting the vaccine is going to reduce your chances of alopecia areata. So get it. And there's a small proportion of people that by getting the vaccine, you may increase your risk of flare. So we have a lot more to learn. We have a lot more to go with understanding these vaccines. And so stay tuned. It's an emerging field. And I'll just briefly review one more study before we leave the alopecia areata field altogether for today. But another really fascinating study by Chen and colleagues titled The Incidence of Alopecia Areata in a COVID-Vaccinated Population, a single-center review in the journal Curious. The authors here wanted to know, very simply, do vaccines cause alopecia areata? And the reason these authors wanted to know, do vaccines cause alopecia areata, is for the reasons I've reviewed. There's all this data all over the place that some people are getting alopecia areata from vaccines. And there's data emerging suggesting that some people are reducing their chances of getting alopecia areata by getting the vaccine. And so what do we do with this information? So the authors here performed a retrospective review of their institution. How are people doing at their institution at the Arrowhead Regional Medical Center in Colton, California? And they looked at alopecia areata diagnoses, new diagnoses between December 2020 and February 2023. And in their institution, they found 1,400,000 vaccinated individuals and 785,000 non-vaccinated people. And they looked at how many get alopecia areata, brand new first onset alopecia areata. Well, the authors found there was 37 cases of new alopecia areata in the vaccinated group and 36 cases of alopecia areata in the unvaccinated group. But the unvaccinated group, of course, was much, much smaller. And so taken together, the authors found that by applying statistical analysis, that the probability of developing alopecia areata after a vaccine was reduced by getting the vaccine compared to not getting the vaccine. So we're actually protecting ourselves by getting the vaccine. And they're forced plots, which is a standard method of showing some of this complex statistical data, shows that amongst everyone in the study, it seems that getting the vaccine reduced the chances of alopecia areata. And amongst the different age groups, didn't seem to have a big difference one way or the other, but certainly didn't cause it. And it did seem in this study, when you compared males and females, that females getting the vaccine were really protected from developing alopecia areata. It dramatically reduced the risk of alopecia areata. So fascinating study, a much needed study. We need these types of studies to really understand what does the vaccine do in terms of the risk. Here in this part of the United States, it seems that getting a COVID vaccine reduced slightly the chance of alopecia areata, certainly didn't increase it. What I liked about this study is the authors are very upfront saying, listen, these studies are challenging to do, and there could be confounding factors. There's limitations to these types of studies. So go ahead and argue all you want, but this is the type of data that needs to be put out there. And it's not a study of 5 people. It's not a case series of 13 people. It's a study of 1.5 million people and 780,000 non-vaccinated people. This is a huge study. And so these types of studies give us information that we can utilize and think carefully about. And so a really valuable study, and we're by no means done thinking about this concept. There are people out there who develop alopecia areata after a vaccine. And there are people out there that are going to reduce their chances of ever developing alopecia areata by having a vaccine. And we don't know which is which yet. So stay tuned. This is an emerging field. We're only 4 years into the pandemic, but we're learning a lot. So I congratulate these authors. It's a wonderful study and really adds to our literature. So we go on now to telogen effluvium. Telogen effluvium is the medical term for a type of hair shedding that happens after a trigger like infections or stress or low iron. And patients with telogen effluvium come into clinic with bags and bags of hair like you see in this picture. Some days they're shedding a lot of hair, sometimes a little bit less. But I'd like to review with you a wonderful study in the JAAD, or the Journal of the European Academy of Dermatology and Venereology, titled Telogen Effluvium in SARS-CoV-2 Infection, Histological Aspects. A really wonderful study that shows that the hair shedding that occurs in patients that have COVID-19 infection may not be your standard telogen effluvium. Hair specialists understand telogen effluvium. We see telogen effluvium after a diet. We see telogen effluvium after stress. We see telogen effluvium after your iron levels go low. But the telogen effluvium that's occurring in COVID-19 just might be a little bit different than what the textbooks tell us. And I'd like to review here why. Specifically, COVID-19 may cause nerves to be thickened, and COVID-19 may cause scar tissue to be deposited in the skin, or what we call fibrosis. So patients with typical telogen effluvium, we tell them your hair is going to grow back. Get your iron levels back, hair will come back. Once the stress goes away, I know you've had some stressful events. Once life returns to normal, your hair will go back. So we make promises to patients with telogen effluvium sometimes that the hair is going to grow back. Don't worry. What this study tells us is that maybe, just maybe, we have to be careful because we're seeing these changes in the skin, including fibrosis, thickened nerves, that we don't see in typical telogen effluvium. And so maybe there's stuff going on in the skin that means that maybe not everyone's going to get their hair back 100%. But we don't know yet, but I'd like to review this study. So generally, hair loss from COVID-19 occurs 1 to 3 months after infection. It can be pretty rapid in some people, even 3 weeks. But in some people, it's 2 or 3 months. And the authors here set out to better understand the hair shedding that happens with COVID. They evaluated 4 patients. It's a small study. But you can imagine if I've included it here, it's because I feel that it's such an important study. They evaluated 4 patients between the age of 53 and 62 with acute hair loss or sudden hair loss starting 1 to 3 months after COVID. They had a positive pull test, meaning they were losing hair. When you looked up close with a trichoscope or a magnifying device, you saw what we see in telogen effluvium. It looked like telogen effluvium. When you pulled hair out of the scalp and looked under the microscope, it looked like telogen effluvium. The biopsies looked like telogen effluvium except for a couple of things. And that was that there was some hairs that were a little bit misshapen, and there was fibrosis, or some scar tissue. And there was also thickening of the nerves, which is called dermal hypernuria. And all 4 of these patients had this thickening of nerves. And this thickening of nerves is something that's been noted by a couple of other authors, including Greco in the Journal of Clinical Medicine in 2022, where the authors of that study noted that patients with COVID infections also had abnormal fibrosis or scarring in the skin, these abnormally shapen hairs, and thickening of the nerve trunks. And in this study by Greco in 2022, you can see nerve fibers that are quite thickened under the microscope, and the development of some scar tissue around hair follicles known as sclerohyalinosis. And these are features that aren't typically seen in a telogen effluvium that we're used to. And so there's this thickening of nerves, this exaggerated size of nerves, which is affecting certain types of sensory fibers. And it's well known that some patients with hair shedding on COVID-19 have pain and burning. And it could be that inside the skin, these nerve fibers are undergoing changes and they're thickening. And that may be responsible for why some people with COVID-19 related shedding have such an uncomfortable scalp sensation. And we see this same nerve thickening in some skin conditions like postherpetic neuralgia, or what happens after shingles infections. Some people have tremendous pain in the face or the scalp. But the authors here propose that this thickening of the nerves might be a part of COVID shedding, and so might be this fibrosis. And the authors propose that maybe this massive inflammation that the body produces to try to deal with the COVID causes these changes in the skin. And so I think this is a really important study, that maybe this fibrosis and maybe these nerve issues might alter the long-term prognosis. We don't know. But one wonders, and many specialists around the world wonder, whether there are some patients, not all, but some patients, who may not get back their hair density to the same level as before they had COVID-19 infection. We need more studies, but I think this study teaches us that when you have a patient with hair shedding from COVID-19, it's probably not appropriate to tell them, once your COVID resolves and once you get better, your hair will grow back. That's what telogen effluvium does. We don't know that. And so I think we just have to be careful. And more studies are needed, and I have no doubt these studies will come. But I congratulate these authors. I think this is a wonderful study, teaches us so much, and continues our understanding of what happens. So we move on to our last few studies. A study of Tinea capitis, or fungal infections. Fungal infections happen in children more than adults. And a really nice study by Gold and colleagues in the Journal of the American Academy of Dermatology in February taught us that we're not doing a very good job treating fungal infections in children. The title, Inadequate Diagnostic Testing and Systemic Antifungal Prescribing for Tinea capitis in an Observational Cohort Study of 3.9 million children. I really like this study. So Tinea capitis is a fungal infection of the hair. Much more common in in children than in adults. But what's so important about Tinea capitis is you need pills or oral treatments. Putting on topical antifungals or antifungal shampoos is not a successful way to treat Tinea capitis. And if you don't treat Tinea capitis properly, people can go on to develop permanent hair loss. And there's lots of people in the world that have had Tinea capitis as children, haven't had adequate treatment, and they have these patches of scars on their scalp. And that's because they weren't adequately treated. So if you treat it properly, most people with Tinea capitis do fantastic. But you have to treat it with oral medications. There's different types of fungal organisms that cause Tinea capitis. In Europe, the Microsporum is the more common, whereas in North America, Trichophyton tonsurens is more common. Children are thought to be more affected because the scalp doesn't have very many what's called fungistatic fatty acids. The scalp doesn't do a very good job at killing fungus. At the time of puberty, the scalp starts making more of these fatty acids that can kill fungus. So the authors here, Gold and colleagues, set out to evaluate patients less than 18, and they looked into a database for children who had Tinea capitis and looked at how they were treated. So they looked at 3.9 million patients, and they found that the incidence of Tinea capitis was highest in 5-year-olds, highest in males, and highest in individuals in the United States that were living in the South. And this is consistent with some other data that Tinea capitis becomes less common as you become 8, 9, 10, 11, 12. It affects younger individuals. Pediatricians were making most of these diagnoses. Dermatologists made some. Family doctors made some. What was interesting in this study is that most children didn't have confirmatory testing. In other words, they didn't have a scraping taken from the scalp, sent off to the lab to see what is it? Is it Microsporum canis? Is it Trichophyton tonsurens? And confirmatory testing was done in only 21% of patients. And despite the textbooks and the teaching that we all get telling us that you have to give oral medications, 40% of children did not receive oral antifungal treatments for their tinea capitis. I think this is a hugely important study because it tells us that we have a long way to go to get practitioners educated appropriately to know what steps to take. And it's often the simple knowledge gap that prevents a practitioner from taking a step that would be appropriate. And so this is important. This means that the ways that we're teaching pediatricians, family doctors, and other physicians around the world in tinea capitis isn't good enough, that we need to do a better job. And we need to encourage practitioners to take samples. It takes time to take a sample. It takes time to send it off to the lab, label it. That's extra steps. But that's really important because some organisms, some fungal organisms are treated differently than others. If you have Microsporum, it's treated slightly different than its trichophyton. And also, species are changing over time. In Europe, there's much more trichophyton happening over time and less Microsporum proportionately. So fungal organisms are changing. And the only way we're going to keep track of the organisms is by culturing them. And it's really important that we get these children on oral antifungal medications because that will reduce their chances of permanent hair loss. And there are children that have permanent hair loss, unfortunately, from fungal infections. So I congratulate these authors. Gold and colleagues have done some wonderful work with many studies in tinea capitis this last year or two. But I really like this study. It reminds us that we need to do better as a professional group in educating practitioners about the treatment of tinea capitis. So we go on now to a study by Landau and colleagues in JAAD Case Reports, which is an equally fascinating study of a side effect that may occur with certain cosmetic techniques known as the temporal lifting technique with dermal fillers. And I congratulate these authors for discussing a side effect of a treatment. And I think when things go right, we like to publish it. When things go wrong, I think we need to publish it as well, because that's how we all learn and that's how we improve the management of our patients. So the authors published a series of patients that developed hair loss after receiving a dermal filler for a cosmetic technique known as the posterior temple lifting technique. I'll explain what that is in a minute. Many of you are aware that one of the signs of aging is we get loss of volume in the temple region. And by increasing volume in this area, we create a more youthful appearance. And so there's many techniques that are looking for ways to increase the volumes in the temple, increase the volume in the cheeks. But these are important cosmetic techniques that we have. And a technique for increasing volume in the temples was published in 2016 in the Journal of Cosmetic Dermatology. And it's called the posterior temple lifting technique. And through this technique, a filler, high viscosity filler, is placed into the temple area. And this increases tension in this area, and that provides a gentle lift to the mid and lower face to help create that youthful look. But it carries a risk of affecting blood flow in one of the arteries that is in that area known as the superficial temporal artery. And so this is a diagram of the face and a diagram of the temple area. And this black dot indicates where these fillers by some practitioners are placed into to try to increase the volume of that area, to try to provide that gentle lift that we're looking for. But what is here is the superficial branch of the temporal artery, the superficial temporal artery, especially this frontal branch. And by putting filler in here, these hyaluronic acid fillers, we increase tension and we potentially affect blood flow in this superficial temporal artery. And so the authors here reported 6 patients that had hair loss with this posterior temple lifting technique. So a really important paper to warn us of some of the limitations with this technique. And so the first patient was a 61-year-old female, and she had 1 milliliter put into these areas that I've showed you. And 24 hours later, she contacted the physician's office saying she's got burning in the parietal area of the scalp. She sent a photograph to the office, but didn't really show much. She just had burning. She made an appointment at the office 36 hours after the injection. She had some redness, some color changes in the scalp and in the temple. And the practitioner recognized that this may be a side effect of the hyaluronic acid and injected an enzyme called hyaluronidase to try to degrade that hyaluronic acid. And so fortunately in cosmetic medicine, we have these wonderful fillers like hyaluronic acid, and we have ways to quickly get rid of them. And that's this enzyme hyaluronidase. And so the practitioner repeated these injections 3 times with an hour break in between, but there was no improvement in pain. And the practitioner did another session of hyaluronidase, again at 24 hours. And finally, the patient had pain relief. But then 10 days later, started to develop itching and hair shedding. And despite platelet-rich plasma sessions, the patient went on to develop hair loss. And 3 months after, there has been some regrowth of hair. But the authors published this data and show these photos in JAAD Case Reports, which is a wonderful journal that publishes free online with this Creative Commons license, so it's accessible to everyone. And you can see this paper. And you can see the tremendous hair loss that developed in this patient with these dermal fillers. Second patient had a very similar story. She was a 44-year-old Asian patient with these hyaluronic acid fillers into the temples. 2 days after the procedure, she had headache and tenderness, but it didn't look abnormal, just headache and tenderness. And 4 days after the procedure, she started getting this red, abnormal appearing color change on the scalp, into the scalp and on the temple. And again, hyaluronidase was injected and injected and injected again. And finally, with enough injections, the patient had a reduction in pain. But on day 9, despite the skin looking pretty good and the pain being gone away, the patient developed a patch of hair loss. And hair regrowth started at month 4. And you can see the non-scarring alopecia, which very much resembles alopecia areata. But you can see this marked red, what's called lividoid color change in this area of the scalp, this reddish color change in the early period before the hair loss occurred. And so in total, the authors reported 6 patients with a very similar story, and that is pain and burning at first, with nothing really abnormal looking, and then hair loss developing about a week later, 9-10 days later. And it was the astute clinician that realized that this is a side effect of the hyaluronic acid and administered hyaluronidase enzymes to break up that hyaluronic acid from the day before that restored blood flow into the area and probably prevented more significant complications. So a really important side effect for us all to be aware of with this particular technique, but also for many techniques that are affecting blood flow into the superficial temporal artery of the scalp. We don't know long-term follow-up for these 6 patients. In 2 patients, there's some improvement that's occurring, but we don't know the final outcome of these patients. Do they all get their hair back 100%? We don't know yet. And in one patient with significant follow-up, the authors said there's still a little bit of hair loss present, but the follow-up isn't long enough for all patients. And so this type of complication can occur with these hyaluronic acid fillers. It can occur when cosmetic physicians and cosmetic surgeons place fat in the area by fat transfer, when they use other types of fillers like calcium hydroxyapatite. And the mechanism of hair loss may be that the filler blocks the blood flow. It may be that by putting the filler in there, you get inflammation and edema, so you get swelling of the tissues, and that blocks the blood. And in some cases, although perhaps more rare, it may be actually that the filler is injected into the blood vessel and it blocks it. But that's probably the least common of the mechanisms. So a really valuable case series by Landau and colleagues about this superficial temporal artery occlusion or compromise from this cosmetic technique called the temporal lifting technique. Really important paper, and I congratulate the authors for sharing this with the world and reminding us that this is something we need to be aware of, and that if we're aware of it quick enough, we can use hyaluronidase to reverse some of this. So we move on now to some scarring alopecias to close off our session for today, beginning first with folliculitis decalvans. Folliculitis decalvans is a scarring alopecia which affects the crown, the back of the scalp, can affect the front of the scalp. Patients often develop pimples that are red, filled with pus. They're crusty. It's itchy. Sometimes it bleeds. And authors in the British Journal of Dermatology, just after we completed our top 20 of 2022, published a wonderful study by Matard and colleagues titled Folliculitis decalvans and Dystrophic Epidermis Bullosa, a Significant Association. This is a really fascinating study for us all to be aware of for patients that treat scarring alopecia. The authors reported 30 cases of folliculitis decalvans developing in patients with this rare disease called dystrophic epidermolysis bullosa. And the authors point that there may be this link between these two diseases that we didn't really appreciate fully before. Epidermolysis bullosa is an inherited genetic disease where people get blistering and skin fragility whenever skin is injured. And there's 4 different classes of epidermolysis bullosa depending on how it appears under the microscope. And that's called epidermolysis bullosa simplex, junctional dystrophic, and Kindler syndrome. But dystrophic epidermolysis bullosa is this genetic disorder where skin and nails are affected. It's usually present at birth. It's not common. So it affects between 2 and 6 per million live births. But the genetics is well understood, and it's due to a mutation in type 7 collagen. These patients get blistering, and the blistering can affect the hands and the feet and the elbows and the nails and leads to significant disfigurement. And it affects the ability to heal wounds if areas are injured because of this skin fragility. And so a number of authors have shared studies and reports and photos online of what dystrophic epidermolysis bullosa does in terms of the scarring it produces, especially in the hands and the feet and the nails. And we need to suspect dystrophic epidermolysis bullosa when we see these types of scarring occurring with minimal trauma. And pediatricians and care for young children are very aware of these findings, and their index of suspicion for these sorts of conditions is very high, and often there's a family history that's present. And many patients go on to have genetic testing to confirm the diagnosis. But what was so interesting about this study by Matard that I want to review with you here is that they looked at 243 patients with epidermolysis bullosa that were seen in their French centers that specialize in this condition. There were 69 patients with EB simplex, 31 patients with junctional EB, 35 with dominant dystrophic, and 108 with recessive dystrophic. So this is a clinic in France which sees a lot of patients with this rare genetic disease of skin fragility. What was so unique is that folliculitis decalvans, the scarring alopecia that I see every day, was highest in patients with recessive dystrophic epidermolysis bullosa. And there's this link between having dystrophic epidermolysis bullosa and folliculitis decalvans. And folliculitis decalvans was found in 28% of patients with recessive dystrophic and 10% of patients with dominant dystrophic. So this clinic in France, which sees patients with epidermolysis bullosa, is seeing a lot of patients with folliculitis decalvans, quite unexpectedly. Folliculitis decalvans didn't occur in EB simplex and didn't occur in junctional EB. It was occurring in the dystrophic EB forms. So all in all, the authors showed that 24% of patients with dystrophic epidermolysis had folliculitis decalvans, and most patients were women. And it's not clear exactly why this is occurring, but it's an important understanding of what's happening. Folliculitis decalvans is a rare condition. It probably occurs in 1 out of every 15,000 people in the world. Dermatologists see it often in clinics, and dermatologists that specialize in hair loss see it often. But it occurs in 1 in 15,000 people. In dystrophic EB, it occurs in 1 out of every 4 patients. So there's this dramatic increase in the chances of folliculitis decalvans in dystrophic epidermolysis bullosa. This is quite an unexpected finding, and I congratulate these authors for publishing this. Folliculitis decalvans is more common in males. So we see slightly greater proportions of males with folliculitis decalvans than females, but occurs in both. But in patients with dystrophic epidermolysis bullosa, it's much, much more common in females. And the authors proposed that perhaps it's different hairstyles and hair pulling and traction in women with dystrophic epidermolysis bullosa that increases the chance of folliculitis decalvans, but that's just a guess. We don't really know why this occurs. But just like there's a skin barrier defect in the skin, maybe even the nails in dystrophic epidermolysis bullosa, the authors propose that maybe that's what's happening in the skin, that our microbiome is changing in patients with dystrophic EB, and maybe that's why it is occurring. So an interesting study, an unexpected finding that gives us some clues to folliculitis decalvans, but I thank these authors that care for patients with epidermolysis bullosa in this French center reporting this particular study. So we'll move on to some studies of discoid lupus, lichen planopilaris, and acne cheloidalis nuchae, and dissecting cellulitis, and we will conclude and open the floor to questions. And if you do have questions, please ask them in the question and answer box, and it will be my honor to answer them for you. Fredeau and colleagues published a wonderful study in March of 2023 in the Journal of the American Academy of Dermatology. Again, a lot of really wonderful hair loss related studies are being published in JAAD lately. I feel it's more and more lately. The title, Risk Factors of Progression from Discoid Lupus to Severe Systemic Lupus Erythematosus, a registry-based cohort study of 164 patients. So discoid lupus is a condition which sometimes causes scarring in the scalp. It can cause rashes and scarring on the face. And patients come into the hair clinic because they have discoid lupus on the scalp, and we are trying to stop the disease so it doesn't go on to cause permanent hair loss. And in the early stages, we can often regrow hair in a significant proportion of people. As the disease gets more and more advanced, it becomes much, much more difficult. And topical steroids, steroid injections, hydroxychloroquine, calcineurin inhibitors are often used. But when patients hear the term discoid lupus, I have discoid lupus, the fear is that this might have something to do with systemic lupus, a medical condition that can be quite serious in some patients. Some patients have mild systemic lupus, but it can be quite serious in some people and affect the heart and the kidneys and the lungs and the brain, and can be extremely serious. So patients that hear the term discoid lupus wonder, does this have anything to do with systemic lupus or SLE? And what's known is that a very, very small percentage of patients with discoid lupus can develop systemic lupus in the future. It's about 5%. And so the key question is, when we see a patient in front of us with discoid lupus, what is their chances of going on to develop systemic lupus? Can we tell them today, I don't think you're going to develop systemic lupus. You don't need to worry about this. Can we tell another patient that I'm worried about some of the things in your story and what I'm seeing? I'm worried that this could be something you might go on to develop. But at the time of diagnosis of discoid lupus, most patients don't have any evidence of systemic lupus. Some patients, however, will go on to develop systemic lupus, and it's often quoted it's around 5%. But the actual statistic ranges depending on the study and the practitioner you speak to, and anywhere from 3 to 11% of patients with discoid lupus will go on to develop systemic lupus. And there's been a lot of studies over the last several years looking at what are the criteria that increase a person's chance. The more widespread lesions you have, the more lesions on the front of the scalp, the back of the scalp, the face, the greater your chances. In some studies, if you have joint pain, if you have nail changes, if you have changes in your blood counts, if you have a positive ANA, these are thought to increase your chances that you may develop systemic lupus in the future. But the thing that's been recognized is that even if a patient develops the criteria for lupus, some patients have a very mild form of lupus. Even though they meet the criteria, they can be said that they have systemic lupus, but it's a mild form that is unlikely to cause them harm. And then there are a group of patients that can develop a very serious form of lupus, which can be associated with several severe medical conditions. So the authors here wanted to try to understand what are the factors that predict if a patient with discoid lupus might develop severe systemic lupus. And so Fredeau and colleagues set out to try to answer this very important question. They studied 164 patients with discoid lupus, and there were 30 patients that developed severe SLE and 134 patients that didn't develop severe SLE. And the authors found there were 3 things that predicted a person's chance of developing systemic lupus. And that was young age, age under 25, having darker skin types, and having a blood test showing an ANA of 1 in 320 or more. So these 3 things are really valuable clues to the possibility that a patient may go on to develop severe systemic lupus. And they developed a rating system with points. And that if a patient was under 25 at the time of diagnosis, they received 1 point. If they had a positive ANA of 1 in 320 or more, they had 5 points. And if they had darker skin, they had 1 point. And depending on how many points in total they had, the authors found this served as a reasonably good estimate of the chances of developing severe systemic lupus. And if you had a score of 0, it didn't seem like you were going to develop severe lupus. If you had a score of 1, you had a 6% chance of going on to develop severe lupus. And as your score increased, your chances of developing severe lupus increased a lot. And if you had a score of 7, so you're age less than 25, darker skin, and positive ANA, you had a 50% chance of developing a severe lupus. So I think this is really important data. Many patients with discoid lupus are worried if they're going to develop systemic lupus. And these 3 criteria are really helpful to keep in mind. That if you see a 44-year-old woman with lighter skin type and an ANA that is low or negative, it's very, very unlikely that that patient will develop severe systemic lupus. If you see a 21-year-old woman with darker colored skin and an ANA of 1 in 640, this is a patient that has a high chance, 50%, to go on to develop severe lupus and really needs close monitoring and rheumatologic follow-up, etc. And so a really helpful study to be able to have easy-to-use parameters that allow us to feel comfortable predicting somewhat. And so I really like this study and use this sort of thinking often in terms of the counseling I do with patients with discoid lupus of the scalp. So we're going to talk about dissecting cellulitis. Dissecting cellulitis is a scarring alopecia that affects young males. It can affect females, but often young Black and Hispanic males. They present at clinic with inflammation in the scalp and pus, and it can sometimes have quite an odor. And they may have nodules on the scalp and what we call sinus tracts. And they may have ridges and furrows. And the ridges and furrows and the valleys and hills can mimic another condition, which is called cutis verticis gyrata. Cajas-Garcia published this really wonderful study in the Journal of the European Academy of Dermatology in February titled Distinct Presentations of Scalp Dissecting Cellulitis Manifesting with Furrows and Gyri. And what they teach us in this paper is that some patients with dissecting cellulitis are going to fool you. Some patients with dissecting cellulitis are going to look like a condition called cutis verticis gyrata. And so be on the watch and be aware. And I love this study because the number of patients that I have seen that I now know with great certainty that this is a form of dissecting cellulitis they have and not cutis verticis gyrata. So cutis verticis gyrata is a condition that is generally in and of itself not harmful to patients, but they have these ridges in the scalp and furrows, so areas that are raised and areas that dip down. And sometimes men that shave their scalp, you'll notice that the scalp's really bumpy. That's cutis verticis gyrata. It's much more common than we realize. And it's said to resemble the appearance of a brain. And if you've ever seen what a brain looks like, that's sort of the ridges and furrows that we see with cutis verticis gyrata. And so these authors here, Cajas-Garcia, tell us that dissecting cellulitis can have these ridges and furrows. And they tell us that there's these 4 forms we need to be aware of. Cutis verticis gyrata is classified into primary and secondary forms. It's classified into primary essential CVG, primary non-essential CVG, and secondary CVG. The reason this is important to mention here today is that patients with primary CVG, they have these ridges and furrows on their scalp. They have no abnormalities in the body, no neurologic disease, no problems internally. They just have the bumps and ridges on the scalp. Primary non-essential CVG is a condition whereby the patient has these ridges on the scalp, but for some reason they have these internal conditions. They have neurologic disease as well, eye findings, deafness, sometimes chromosomal abnormalities. And so when you see a patient with CVG, you have to ask yourself, I wonder if I should refer this patient to a neurologist or ophthalmologist or hearing test or geneticist. And then there's secondary CVG, where patients have these ridges and furrows on the scalp, but they have an underlying inflammatory scalp problem. And that's why they have the ridges and furrows. And dissecting cellulitis is on that list. So when you have dissecting cellulitis in the scalp, sometimes it causes ridges and furrows. It looks just like cutis vertices gyrata. It can fool you. And so the authors here teach us that you may be fooled and you do not need to be fooled. So there's these 4 variants that they tell us. One is dissecting cellulitis, that when it causes scarring in the skin, it creates these folds that look like cutis vertices gyrata. And they explain that if you have dissecting cellulitis that goes on long enough, that sometimes what happens is you get scarring that forms, and this scarring creates a fold and a ridge that looks like cutis vertices gyrata. So that's the first type that they mention. The second type is a patient that has dissecting cellulitis developing after long-standing cutis vertices gyrata. And so they tell us that some patients have cutis vertices gyrata for many, many years. And then what can happen is that some patients can develop dissecting cellulitis in that skin of patients with cutis vertices gyrata. It's not known why a person with cutis vertices gyrata can develop dissecting cellulitis, but it's thought that these skin folds trigger changes in bacteria, flora, and the microbiome, and perhaps they predispose patients to dissecting cellulitis. The third type of dissecting cellulitis is a patient that has dissecting cellulitis, and when you apply pressure to the scalp, you get a fold that looks just like cutis vertices gyrata. And when you relieve your hands and no longer apply pressure, it goes back to just looking like dissecting cellulitis. But when you apply pressure again, it looks like cutis vertices gyrata. And then there's finally a fourth form where when you apply a patient with dissecting cellulitis, when you apply pressure, you get these ridges and folds across the entire scalp that looks just like cutis vertices gyrata with these ridges and folds. So all in all, these authors point out that there's these 4 presentations of dissecting cellulitis that look just like cutis vertices gyrata. And so when you're seeing a patient with cutis vertices gyrata, you need to determine in your mind if it's primary, essential, primary non-essential, or secondary. And there are a lot of patients with dissecting cellulitis, seborrheic dermatitis, psoriasis, all of these inflammatory scalp diseases that look just like cutis vertices gyrata. And the treatment should be the treatment of the skin disease, the treatment of the dissecting cellulitis, the treatment of the psoriasis or seborrheic dermatitis or whatever inflammation is there, not running off to the surgeon to cut out the folds and ridges, not performing injections of hyaluronidase. So not actively treating the CVG, but rather treating the inflammation. And so this study reminds us that there are patients with these ridges and folds that look just like CVG, cutis vertices gyrata, that really have dissecting cellulitis, and they're going to fool you. And so be aware of it. I really like this particular study. We go on to talk about lichen planopilaris. Lichen planopilaris is a scarring alopecia that affects men and women, but it often affects the central scalp. It causes itching and burning and redness and pain and shedding. Lim and colleagues published a wonderful study in Clinical and Experimental Dermatology titled The Prevalence and Incidence of Comorbid Diseases and Mortality Risk Associated with Lichen planopilaris, a Korean nationwide population-based study. So a study from Korea, which teaches us some very valuable information about the diseases associated with lichen planopilaris. So we're beginning to understand that patients with lichen planopilaris, the scarring alopecia, may have other medical conditions going on at the same time, or they may develop it in the future. Dr. Connick and colleagues in 2021 published a really wonderful study that got us thinking about this concept. Her group compared 3,000 patients with lichen planopilaris to 63 million controls and found that patients with lichen planopilaris, the scarring alopecia, had increased risks of high cholesterol, high blood pressure, 5-fold increased risk of obesity, 2.6-fold increased risk of diabetes, and a 10-fold increased risk of metabolic syndrome. A 1.7-fold increased risk of coronary artery disease, 1.5-fold increased risk of heart attacks, 1.6-fold increase of atrial fibrillation. So a really important study that got us thinking that patients with lichen planopilaris may have these comorbidities that we really need to address. And perhaps we're not doing a good enough job in making sure that cholesterol is optimized, blood pressure is optimized, diet is optimized, weight and BMI is optimized. After all, we're quite focused on the scalp and preserving the scalp, but there's these other issues that are so important. Joshi and colleagues published a study last year looking at some of these comorbidities as well, and found that patients with lichen planopilaris had an increased risk of a variety of conditions: psoriasis, atopic dermatitis, melanoma, basal cell cancer, squamous cell cancer, inflammatory bowel disease, rheumatoid arthritis, lupus, ischemic heart disease, high cholesterol, high blood pressure, anxiety, depression. And so these studies by Connick and colleagues, Joshi and colleagues, have really introduced into our literature important concepts that there are these comorbidities. There are these other medical issues occurring in our patients with lichen planopilaris, and we're just not sure yet what to do with this. And we need to. And so Lim and colleagues have another study that adds to that body of literature. And they show that at the time of diagnosis, patients with lichen planopilaris have an increased risk of lichen planus, psoriasis, atopic dermatitis, lupus, rheumatoid arthritis, allergic rhinitis. And if you follow these patients long enough, some patients who don't have these diagnoses at the time of their first visit can go on to develop lichen planus, psoriasis, atopic dermatitis, lupus, arthritis, and rhinitis. And that same is true for hypothyroidism, and the same is true with low vitamin D levels. So there's these comorbidities that exist in lichen planopilaris, and this is another one of these wonderful studies that teach us that there is a higher risk of these conditions. And when we see patients with lichen planopilaris, we need to really make sure that blood pressure has been checked, cholesterol has been checked, blood sugars have been checked, that we know the type of diet patients eat, whether they are overweight or whether they are obese, and to think about some of these other comorbidities. These are really important issues that I think will become a part of the thinking that we have in the hair world over these next 5 and 10 years, but these are somewhat new concepts. Kim and colleagues just published another wonderful study in the Journal of Investigative Dermatology last month titled Association of Primary Cicatricial Alopecia with Subsequent Cardiovascular Disease, a study from Korea, which builds on this concept by Connick and colleagues that there's an increased risk of cardiovascular disease. And as I just mentioned, Connick and colleagues taught us in 2021 that there's all these metabolic syndrome related issues. And so this study in the Journal of Investigative Dermatology set out to answer the question, are patients with scarring alopecia at increased risk for cardiovascular disease? And so they set up to determine if there's an increased risk of cardiovascular disease, coronary artery disease, or stroke. And they performed a large study with almost 8,000 patients with primary scarring alopecia, 78,000 patients with non-scarring alopecia, and 319,000 controls. And patients were from this Korean National Health Insurance Service database, this wonderful database in Korea where you can mine some of this data from. And patients were followed up until from 2013 to 2020, and they were followed up until the end of 2020, or until they had a heart attack or a stroke, or until they died. They studied lichen planopilaris, pseudopelade of Brock, folliculitis decalvans, dissecting cellulitis. The mean age of patients was around 36, 65% were men. And here's the important point of the paper, that after adjusting for all sort of confounders or things that can confuse the data, like the age of the patient, sex, income, smoking, alcohol, blood pressure, blood sugars, cholesterol. After taking all that into account in fancy statistical methods, the authors found that patients with scarring alopecia had an increased risk of heart disease, cardiovascular disease, and coronary heart disease. An 18% increased risk of cardiovascular disease, 26% increase in coronary heart disease. And when you broke this down into specific scarring alopecias, it was found that patients with folliculitis decalvans had an increased risk of cardiovascular disease and stroke, a 29% increased risk of cardiovascular disease, 39% increased risk of stroke. And patients with lichen planopilaris frontal fibrosing alopecia had an increased risk of coronary heart disease, 93% increased risk. When they evaluated their data, this large data from this Korean database, according to males and females, they found that most of this risk is in males. So it's males that are at increased risk of cardiovascular disease, coronary heart disease, if they have scarring alopecia, not so much in women. And so folliculitis decalvans, LPP, these are the scarring alopecias that are associated with these conditions. Dissecting cellulitis and pseudopelade don't seem to have this same risk for reasons that aren't entirely clear. But the authors feel that perhaps it's this abnormality in lipid metabolism. It's known that deregulation in lipid metabolism occurs in scarring alopecia. It's been best studied in lichen planopilaris. And changes in the PPAR gamma pathway, but changes in how cholesterol is regulated and the metabolism of lipids is different in scarring alopecia. And perhaps it's the same dysregulation that's occurring in patients that's giving them an increased risk of heart disease, stroke, coronary heart disease. And this is particularly relevant in males. So I congratulate these authors, Kim and colleagues. I think this is a really important study. It sheds new light on folliculitis decalvans. We've known from Connick and Joshi that lichen planopilaris might be associated with these risks. But now we have folliculitis decalvans on that list as well. And now we have data showing us that it's particularly males that we need to pay attention to. But I think this is important. As a hair community, we don't talk much about cardiovascular disease and heart attacks and strokes and high cholesterol. And we don't talk about this. We talk about scalps and shedding and itching and burning and what cream and lotion and pill put on to stop hair loss. Because that's of course one of our main jobs as practitioners is to help the patient save their hair. But we desperately need this second step of communication, that is to realize that these patients are at increased risk for heart attacks, strokes. And it's a challenging field, and that's why I'm so glad to be able to discuss it again today. We've known for 50 years that patients with androgenetic hair loss are at increased risk for heart attacks and strokes. And that discussion almost never occurs in a clinic. And that's been 50 years. And so you can see how challenging these subjects are. but I think that we as a community can do better to get these important messages out. How to do it, we don't know. How to screen, we don't know, but I thank the authors for this paper. We go on to central centrifugal cicatricial alopecia, a scarring alopecia that occurs in Black women at much higher rates than we currently realize or that we currently diagnose. CCCA often starts in the central scalp. It may or may not be itchy, but it moves out over time and creates larger and larger areas of hair loss. Joshi published a very nice study looking at the comorbidities that occur in patients with CCCA. What are the diseases that are more likely to occur in someone with CCCA? This is not the first study that's looked at this, and prior studies have looked at what medical conditions may be more likely in someone with CCCA. Studies have looked at perhaps there's an increased risk of diabetes, metabolic dysfunction, bacterial skin infections, uterine fibroids, maybe even breast cancer. But this new study by Joshi shows that patients with CCCA may have a higher risk of autoimmune diseases, atopic diseases, metabolic diseases, and even depression and anxiety. So they performed their study by looking into an NIH database known as the All of Us Research Program, this database with large numbers of patients. They found 201 patients with CCCA and matched them to controls that didn't have CCCA, including age, race, gender, and ethnicity-matched controls. And they found that patients with CCCA, compared to controls, had a higher risk of hyperlipidemia, high cholesterol, an 8.6-fold increased risk of high blood pressure, a 5.7-fold increased risk of diabetes, an increased risk of allergic rhinitis, asthma, atopic dermatitis, a nearly 5-fold increased risk of autoimmune diseases, a 5.4-fold increased risk of anxiety, and a 3.2-fold increased risk of depression. So a really important study, again, that gets us thinking that CCCA has these unique set of associations and comorbidities that we need to be aware of. And it very much matches other studies showing that women with CCCA are at risk for metabolic dysfunction in particular, high blood pressure, high cholesterol, diabetes. Not all studies have shown the relationship to diabetes and CCCA, but many have. And now this study by Joshi shows that maybe there's this link to autoimmune conditions. Maybe there's a role for abnormal T cells in CCCA. And there's this link to allergies. And so maybe there's a link to abnormalities or alterations in what's called the Th2 axis, or this allergy response that's occurring in patients with CCCA. So we certainly have a long way to go to understand exactly what happens in CCCA, but we're learning a lot about CCCA in the last few years. CCCA is also associated with, in one study, a higher risk of breast cancer, and in other studies, a significantly increased risk of uterine fibroids. And it'd be interesting if this All of Us database can show any of those associations as well, because those are particularly important as well. But I really like this study, and I congratulate Joshi and colleagues for this study and using the All of Us database to really mine such important research that answers some really important questions. I think that as we learn a lot about CCCA, we need to take into account these other comorbidities that are occurring. And just like in LPP and FFA and folliculitis decalvans, we need to make sure that we have all aspects of the patient's health taken care of. And finally, a wonderful study of acne keloidalis nuchae. And then I will be delighted to answer any questions that you have. Please enter them in the chat box, and I will answer them. Acne keloidalis nuchae is a condition where people get bumps and papules on the back of the scalp and the neckline. It can occur in different races. It's more common in darker colored skin. But these bumps can coalesce and merge together to form thick plaques, and they can be quite disfiguring. And so it's a type of a scarring alopecia that fits in this category of what we call mixed scarring alopecias because it has this mixed pattern of inflammation. But patients get papules and nodules and sometimes very large tumorous masses. And it's not clear what causes it, but it's thought that perhaps injury to the scalp does something because close shaving and use of razors for haircuts is thought to be a predisposing factor, but other factors are relevant as well. Heat, humidity, friction. We don't fully understand what causes acne keloidalis nuchae. But what is clear over the last few years is that acne keloidalis can occur more commonly with certain conditions, like metabolic syndrome, which includes high blood pressure, diabetes, high cholesterol, obesity. So patients with acne keloidalis are more likely to have those conditions. It's more likely to occur in folliculitis decalvans, and patients with acne keloidalis are more likely to have pseudofolliculitis Barbi, or a similar inflammatory response from inflammatory hair reactions. So Lobato Barizo performed a really nice study in the Journal of the European Academy of Dermatology and Venereology. I really like this study. It's an international study of patients with acne keloidalis nuchae. And it was a study drawing from patients from Spain, from Australia, from Italy, and these were patients with acne keloidalis nuchae. 75 men, 4 women. 35 years of age was the median age at diagnosis. Patients were of many different racial backgrounds: Caucasian, Middle Eastern, African, African American, South American, Asian. Now, of these 79 patients, 38% had straight hair, 25% had wavy, 38% had curly, so a variety of different hair types. 41% had used a razor on the back of the scalp. 17% had previously used a helmet. So these are some of the factors that are thought to be related to the triggering of acne keloidalis nuchae, but clearly not everyone used those. Not everyone had those. But in terms of comorbidities, metabolic syndrome associations were quite prevalent. 67% of patients had obesity, 13% dyslipidemia, 9% had acanthosis nigricans, or this discoloration on the neck, which is associated with metabolic syndrome. 6% had hypertension, 5% had diabetes. 20% had pseudofolliculitis Barbi, 20% had folliculitis decalvans, and 6% had dissecting cellulitis. I really found that very interesting because it reminds us that we shouldn't be confused if we're seeing a patient and we think, is this acne keloidalis nuchae or is this folliculitis decalvans? I can't tell. Well, it may be both. Is this acne keloidalis nuchae or is it dissecting cellulitis? I can't tell. Well, it may be both. I think that's really important because these conditions are much more common than we realize, and many studies have shown that, and here this study verifies that. But what's also interesting is that a high percentage of patients with acne keloidalis have what's called follicular occlusion. And follicular occlusion is this phenomenon whereby hair follicles collapse, the wall collapses, and you get this inflammatory response. And it can produce acne conglobata, this severe acne on the back, and cause hidradenitis suppurativa, these boils in the armpit area and in the groin. Dissecting cellulitis is part of the follicular occlusion, and pilonidal cysts, sinuses in the buttocks area. And all of these were seen to a certain degree in patients with acne keloidalis nuchae. And so I think this is really important because it reminds us that when we see a patient with acne keloidalis nuchae, and we realize, those are the bumps on the back of the scalp, I know what this is. We have to make sure we do a full scalp examination. seeing if there is any evidence of another scarring alopecia or another condition, maybe folliculitis decalvans, maybe dissecting cellulitis, maybe androgenetic hair loss, maybe something else. We have to check for pseudofolliculitis barbae. Is this patient affected by a similar inflammatory scarring response on the face? But I think we also need to ask about these follicular occlusion issues. Severe acne on the back, boils in the armpit and groin. Patients that come in to see a hair doctor for bumps at the back don't feel that talking about boils and drainage in the armpits has anything to do with today's visit. But it does, because that's hidradenitis suppurativa, a very disabling condition that patients feel very, very affected by, are hoping to talk to someone about it and sometimes don't know what it is, and they may not bring it up at the meeting. And so we have to ask, do you have any drainage? Do you have any lumps or bumps? Do you have any fluid that comes out of the armpit or the groin or the buttocks area? Patients are sometimes too embarrassed to tell you, but we need to ask. And this study really reminds us that acne keloidalis has these associations, and so it's much more than just bumps at the back of the scalp. How is it treated? Well, in these 79 patients, intralesional steroids was the most common treatment, followed by oral retinoids, vitamin A derivatives, and oral and topical antibiotics. And a whole host of treatments were discussed by the authors. 19% of patients, the authors tell us, had no improvement. But a high proportion of patients had improvement. 26% had mild improvement, 18% had moderate improvement, and 37% had significant or complete improvement. And I think that's really, really important. 55% have this moderate or significant improvement. I'm asked by patients with acne keloidalis nuchae all the time. Just the other day, is it worth treating? Am I going to get any improvement? Well, this study gives us great hope that 55% have moderate to significant improvement. That's fantastic. And another percentage have mild improvement, but 80% have some kind of improvement. So I think that's really important. The authors here don't look at their data in terms of what actually caused the improvement, which was the best, what patient responded best. So they don't go into that detail in their data, but they describe this array of different treatments. And, steroid injections was at the top of the list. And I think that's so important because we need to remember that steroid injections, when performed with the right technique, spaced out far enough, these can be very helpful treatments and relatively safe. And, before we go down the list to more and more treatments, we're using everything for acne keloidalis nuchae now. Lasers, surgery, JAK inhibitors, other immunosuppressants, dozens and dozens of treatments. Before we go down that list, we've got to make sure we use treatments that have pretty good safety, effectiveness, and steroid injections are certainly on that list. So I was glad to see that. Who's most likely to benefit from the treatment? Well, patients with less than 3 centimeter distribution of lesions. When you look at how far spaced the lesions are in the back of the scalp, or patients with discrete papules or nodules had a greater probability of improvement. And if you had more than 6 centimeters of distribution, or there was merging papules and nodules, you were less likely to respond to treatment. I think that's really important as well, that patients with limited localized disease can often do quite well. And it also tells us that patients with more advanced disease, we need to be a little bit more aggressive. That using a topical steroid on someone with coalescing nodules is probably not the answer. It's not going to help. And so in that case, we may want more aggressive treatments, and we may want to start getting our surgical colleagues in the dialogue as well for some of the more advanced surgical options for acne keloidalis. So I really like this study, and I congratulate the authors. It draws attention to this scarring alopecia, which is very much a challenge to treat. We still don't fully understand it. It's clear that trauma and injury is relevant. Friction, humidity is relevant. There's limitations to this study. There's not a control group, so we're not comparing it to another group in terms of the data. And we don't match up the treatments with what works. But nevertheless, a really nice study which reminds us of all these important disease associations, the associations with metabolic syndrome, the associations with acne keloidalis nuchae and folliculitis decalvans, and dissecting cellulitis, and pseudofolliculitis barbae. And I think it's important, this association with metabolic syndrome, and other studies have drawn this association with metabolic syndrome. Our patients with acne keloidalis nuchae, not only in this study, but other studies like this 2020 study by Cradin, show us that our patients with acne keloidalis nuchae are at increased risk for diabetes, hypertension, high lipids, metabolic syndrome. They're at increased risk for all these things that contribute to cardiovascular disease, strokes, heart attacks. And so it's really, acne keloidalis is really a call to action to make sure that we have these difficult discussions sometimes with patients and make sure that their health is optimized and make sure that they're aware of these things. I think we're coming to be aware of that in many aspects of the hair loss world, that there are these associations that we just can't ignore. And so I think that the other thing that I mentioned, which is so important, is that we mustn't ever be afraid to diagnose 2 conditions in a patient, or 3, or 4, or 5, or 6. So if you have acne keloidalis nuchae and folliculitis decalvans, that's okay. They can occur together. If you have acne keloidalis nuchae and dissecting cellulitis, that's okay. They can occur together. And again, we need to be asking about all those components of the follicular occlusion triad: the hidradenitis under the armpits and in the groin, the pilonidal cysts in the back of the buttocks area. These are things that we just need to ask for because our patients aren't going to spontaneously tell us. But we need to give them hope for treatment because 55% of patients are going to get some pretty decent improvement if we use the right treatments. So I think that's a really important message of this study. And so I congratulate these authors for this really nice study of 79 patients with acne keloidalis nuchae. I really liked this study. And so that brings us to an end of another year of wonderful hair loss research going on in the world. These are the top 20 studies of 2023. And I thank everyone for taking the time to join me. I hope this was interesting and informative, whether you're a practitioner or a patient. The message is overall that we are learning a tremendous amount about hair loss, and it's moving forward at a very rapid pace. And we're learning that these diseases have these associations, that if you diagnose a person with lichen planopilaris, that there's these other conditions that sometimes go along with it. We need to know them. When you diagnose a person with alopecia areata, there's these other risks that seem to go with it. And in alopecia totalis and universalis, it might be higher risk of infections, blood clots, cancer. But we need further confirmatory studies in all these areas. But we're learning a whole lot about these comorbidities. I sincerely thank you again for joining me. I hope that you'll join me again for our top 20 studies of 2024. This will be on our YouTube channel and posted on the Evidence-Based Hair podcast. If you'd like to review it again, there's webinars that occur throughout the year, and those are on our website.